We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, APIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Well, hey, Jess, how are you doing?
Good. How are you?
I am pretty well, thanks. I know this is an evergreen show, but we do have spring coming around the corner, so I have a question for you.
Okay, great.
Okay. What do you get when you cross a rabbit with an amoeba?
I don't know.
An amoebit? It can multiply and divide at the same time. The reason I picked that joke is because we're going to be talking a little bit about multiplying and division today. And we've got Joan Hebden, Dana Piatek, and Dr. Katreena Merrill with us to talk about the different divisions within IP and how to get the field to multiply. I know that was a stretch with the joke, but they are going to talk to us today about their research findings in infection preventionists in public health, consultant, and academic roles, results from the 2020 APIC Mega Survey. So Joan received her baccalaureate and master's degree from the University of Maryland School of Nursing. She's currently the president of IPC Consulting Group, LLC, a Maryland-based company providing infection prevention consultation in acute and non-acute healthcare settings, and is a research coordinator for the University of Maryland School of Medicine, Department of Epidemiology and Public Health. She served as the Director of Infection Prevention and Control for 28 years at the University of Maryland Medical Center in Baltimore, Maryland. An accomplished practitioner, Ms. Hebden is an invited speaker at national epidemiology conferences, participates in research to identify best practices for the prevention of healthcare-associated infections, and has multiple publications in medical and infection control journals. She is certified in infection prevention and control through the Certification Board of Infection Control and Epidemiology. She's an active member of the Society for Healthcare Epidemiologists of America, better known as FSHEA, and the Association for Professionals in Infection Control, also known as APIC. She also serves as a board member and a reviewer for the American Journal of Infection Control and is a fellow of APIC and FSHEA. She was the recipient of the 2018 FSHEA Advanced Practice IP Award. That is quite an accomplishment, all of those. Dana is an MPH, an MSN, an RN, a CIC, and a FAPIC. She's a registered nurse with over 30 years of healthcare experience in various settings, including acute care, long-term care, and public health. She began her career in infection prevention in 2010 in a dual role as a staff development coordinator / infection preventionist within the long-term care setting. Dana also has extensive experience managing the infection prevention department for multiple hospitals and hospital-based outpatient sites. She's been an IP with the Bureau of Epidemiology in the Pennsylvania Department of Health, where she was the regional lead for Northwest Pennsylvania's Infection Control Outbreak Response Team, as well as the Infection Preventionist Supervisor for the Project First Line grant. Currently, Dana is a clinical consultant with GOJO Industries as part of their Purell SmartLink team. She began her nursing career with a diploma in nursing from St. Francis Hospital School of Nursing in Newcastle. She went on to earn a bachelor's degree in nursing science from Edinburgh University of Pennsylvania, a master's degree in nursing science with a concentration in education and leadership from Carlow University, and a master's degree in public health with a focus in epidemiology from Georgetown, Washington. She went on to earn a bachelor's degree in nursing science from Edinburgh University of Pennsylvania, a master's degree in nursing science with concentration in education and leadership from Carlow University, and a master's degree in public health with focus in epidemiology from George Washington University. She achieved board certification in infection control and infection prevention and control with the CIC designation in 2015 and in 2022, She was awarded status as a fellow of the Association for Professionals in Infection Control and Epidemiology. Dana is a member of multiple professional organizations, including APIC, FSHEA, and CSTE. She has contributed to the profession as a subject matter expert, including publication and peer review activities for the American Journal of Infection Control, presentations at invited seminars and scientific meetings, as well as podcasts. And we have Dr. Katreena Merrill, who is a professor at Brigham Young University College of Nursing in Provo, Utah, where she teaches interprofessional education, ethics in nursing, and pediatrics. She also works as a nursing research consultant for Intermountain Healthcare. She's been a nurse for over 40 years, where she started her career at Primary Children's Hospital in Salt Lake City, Utah, specializing in infection prevention, control, and continuous improvement. She continued her nursing quality and research work with Intermountain Healthcare and served as a magnet program coordinator. Dr. Merrill's research focuses on patient safety in healthcare, emphasizing the prevention of healthcare-associated infections, or HAIs, and she's published and presented nationally and internationally about HAI prevention. She is certified in infection control. She is a fellow of APIC, and she's a fellow of the American Academy of Nursing. In her spare time, she enjoys walks with her golden retriever, visiting grandchildren, and refinishing old furniture. Dr. Merrill, I love a crafty hobby. Is there a piece of refinished furniture, anything you've refurbished that you've done that sticks out in your mind, a favorite?
Yeah, probably my COVID table. I had an old table that had years of wear, and the kids had, carved their names in it and stuff. And so I refinished it. And it just became such a hobby now that I look at thrift stores and garage sales for furniture, and I'm a little bit over furniture at the moment, but
it's time to sell, time to refurnish and sell.
Yes. I just haven't been able to part with my hard work.
Yeah, you get attached to those little works and you're proud of them and don't want to let them go. Well, I'm sure your family would love to be the recipients of some of those.
That's true.
Now, Dana and Joan, any hobbies of yours?
I as well have a little dog. Our dog is a mixture of breeds. Primarily, we think Chihuahua, and my husband and I enjoy her immensely.
Wait, and Chihuahua and what?
We're not exactly sure. It could be Chihuahua and Beagle. Mm-hmm. We're not really sure. She's about 22 pounds, and she has a coat that is very much like a German Shepherd coat. But based on her size, I don't think there's much German Shepherd in her, but perhaps Beagle.
I was thinking that would be a big German Shepherd and a Chihuahua. That'd be a big spread.
Yeah, but anyway, we delight in her, and I also enjoy renovating our home currently to make it more comfortable for the older years. So that's what I'm up to.
And I actually have a English Springer Spaniel who I am praying stays in the bedroom and doesn't want to talk on this podcast.
That's okay, Dana. He can come give his opinion on IPs.
Well, when I was with the health department, I used to introduce him as Dr. Squirrelington, my guest lecturer.
It's really cute.
My hobby is a little bit different. I actually am addicted to dragon boating. I joined a team last summer and out of Pittsburgh, and it's the Steel City Dragons. We compete and practice weekly during the spring, summer, and fall. And I get to go out on the river and paddle to my heart's content.
How interesting. That's really neat. Well, ladies, that's a really neat collection of hobbies. And I'm appreciative of the chance to get to know you guys a little more. I think we should get to know all of our IPs a little more. And I think you guys did a really good job finding a little bit more out about the IPs in the country. So kick us off and let us know what prompted the study.
This is the second study of the Mega Survey for APIC. The original survey was in 2015, and we repeated that survey in 2020. Interestingly enough, we finished it right before the pandemic. Mm-hmm. And this is interesting almost baseline prior to the pandemic information about the IP workforce.
So in 2020, a bit over half of the IP respondents report acute or non-acute care arena. Dana, can you talk a little bit about what opportunities there are outside of the acute care hospital setting? What are those non-acute settings that IPs might be working in?
Absolutely. So what we saw from this survey was ambulatory surgical centers, dental practices, dialysis, home health, and home infusion were some of those non-acute settings that we saw.
The article talks about IPs as consultants and indicates practice settings like long-term or long-term acute care. And I picked that out because I wanted to know if you had a breakdown on it. I know I'm long-term acute care, and I consider myself more acute care than skilled care, and I think a lot of the LTACs do. So I didn't know if you had a breakdown of what you were talking about there.
That's a good question. The respondents self-identified as to whether they were long-term care versus long-term acute care. And so I think that, and we don't know much more about that, but I think the key message here is that patients who are in long-term care need infection prevention.
Definitely have,
Joan has some
a different set of needs
that she can share about consultants.
Yeah, hi. I was really delighted to see that we had 39% of the respondents be identified as consultants. I think that there is a plethora of experienced infection preventionists that can provide consulting, mentoring, as well as coaching to infection preventionists, not only in the acute care setting where we tend to have a higher staffing ratio per beds, as well as, I think, higher educational levels. Whereas in the long-term care setting, where we do have some consultants currently working, we have a lot to offer them in terms of increased proficiency with competencies of infection prevention, assisting them with achieving certification. It was interesting to note that for the consulting group, we had individuals that were certainly higher level as it relates to education, but also they tended to be individuals that felt very satisfied in their work. They felt that they were either proficient or expert in all of the IP competencies, as well as being very satisfied with their salary. So again, I think there is going to be a need for consultants in the future to serve somewhat in interim roles, as well as to be stepping in to assist with mentoring, particularly in the non-acute care settings.
So, Joan, along those same lines, I think probably both Nikki and I, as well as a number of other infection preventionists, experienced during COVID questions coming from outside of healthcare around infection prevention. Mm-hmm. Do you think that there's a role for infection preventionists in things like restaurants and schools and other external areas in like industry?
I do. I would say that most of the respondents that were consultants in this particular survey were nurses, and only about 10% of them had public health background. I do think that those in public health, and we have really embraced them joining our discipline because they do have, I think, a better understanding of what is going on in the community outside of healthcare settings and can be instrumental in assisting industry as well as the school system with education. I know that many IPs do volunteer, for example, to go out and assist. And certainly during the pandemic, I did some very unusual things. I was involved with promotion of infection prevention practices with Netflix, actually went to production sites to help to enforce practices and dealt with their catering services. I also went into some of the colleges and provided consultation as well as daycare. So the pandemic sort of opened up a lot of other opportunities for me as a consultant to be engaged outside of the healthcare setting.
Okay, so Joan, we're going to need to get together after this to find out how we can also consult for Netflix.
Yeah, exactly. That's so neat. Did they find you or did you find them?
They found me through a physician that I work with at the University of Maryland. There were a couple of us in Baltimore that became involved. So I actually have a credit as an infection prevention consultant for the Pinocchio film that was done by Del Toro.
Netflix, we exist too.
Thinking along those lines and what you had said, between working with public health and then the healthcare infection preventionists, that partnership, and it makes me think of what we always say, which is infection prevention is everyone's job, right?
Mm-hmm. Yeah. Yep. It sure is. And it's one of the things that I've found to be a deficiency when I go into long-term care settings, because there's always this perception that the infection preventionist is a nurse and therefore they focus on nursing, but they don't really appreciate their responsibilities as it relates to other departments, dietary, facilities, environmental services, the activities areas, and disinfection of equipment, things of that nature are really needing to be emphasized with that group, many of whom are novice and have very little experience.
Yeah, who knew you were going to have to know that much about HVAC systems?
Right? Exactly. Yeah, I was surprised about that when I started. And we are, as the article states, we're trying to grow a more seasoned infection prevention and control workforce. Dr. Merrill, this might go to you, but anybody can hop in here. Has APIC discussed any strategies for getting a more seasoned IPC workforce?
Yeah, is really at the forefront of this. And I think it's understanding what was in the 2015 and the 2020 Mega Survey. They have launched a couple of initiatives. In 2021, APIC was chosen as a subcontractor to conduct research and provide recommendations for infection control coursework for vocational programs, community colleges, and schools and programs of public health. There's also the IP Academy pathway, and this is an initiative where APIC plans to partner with colleges and universities to design a certificate program, as well as a bachelor's and a master's degree program to prepare students for careers in infection prevention and control. They also have a very robust competency model and resources to support professionals currently practicing in the field. And they want to create a clear pathway into infection prevention careers that doesn't necessarily exist currently. The APIC public policy agenda, as part of the omnibus last year, they worked with allied organizations to pass a loan repayment program for individuals entering infectious disease professions. Unfortunately, while it was passed, it wasn't funded, which kind of goes hand in hand. Without funding, you can't really do it. And so APIC is working to request $50 million in funding for this. They've also published some talking points justifying the need for a stronger IPC in nursing homes based on the 2022 GAO report. And I think that this has really come to the forefront as with COVID and the aftermath of COVID.
I noticed you talked earlier about infection prevention kind of focusing on nursing, and a lot of nurses got into infection prevention and control, but I noticed that the percentage of respondents from 2015 to 2020 that reported nursing as their background is decreasing. Of course, as a nurse, I'm partial to them, but Jess and I are definitely of the opinion that multidisciplinary approaches in IP are very good. I learned alongside a micro guru. Jessie is a micro guru. So I love multidisciplinary teams. How do you all feel about this?
I think it's absolutely fantastic to see this happening. After talking about it, I've always been of the mind that to have the best IP team, you need all the different factors and facets that we have to deal with all in one. So you have your nurse, you have your MPH, you have your microbiologist. And when you mentioned HVAC, even looking at industrial hygienists, including them on your team.
Yeah.
Do you have any indication of why potentially some of these other types of education and experienced individuals are actually joining the IP field?
So I actually found some interesting, if Dr. Merrill and Joan don't mind, I looked at this one and really came up with some interesting stuff. I think it's with the spotlight of the pandemic really showing on infection prevention. How many
that makes
people
sense.
didn't even know exactly what I would say I was an infection preventionist, and people would look at me with glassed over eyes that they didn't even understand what it was. There's also this new emphasis on population health, quality of care, interprofessional collaboration, and the values of services that we're delivering. It's that the biggest bang for our buck now. So everybody wants to get involved. And it actually reflects recommendations from the 4-phase National HAI Action Plan, calling for that increased collaboration among diverse resources so that we can expand our HAI profession efforts to even include ambulatory care and long-term care.
That's fantastic. The article actually suggests that maybe a Master of Public Health would be the graduate program of choice for an IP. Dr. Merrill, do you want to talk a little bit about the programs that are geared specifically toward infection prevention and whether or not APIC has actually considered any scholarships?
Yeah, that's a really good question. We talked about the loan repayment, but there are some scholarship availabilities. There's scholarships for critical access hospitals, for the APIC conference itself, certification support, and then there's a graduate student award, which helps fund graduate students doing their projects. And there's also the Bartley Advocacy in Action Scholarship that's awarded jointly with APIC and FSHEA. And that is more towards cultivating and sustaining public policy. The Critical Access Hospital Scholarship started this year. So it's the inaugural year of it. And by December 2026, 9 facilities will have completed the program. And each scholarship is $50,000. And each hospital receives up to 150 hours of free consulting, 2 free APIC memberships, subscriptions to AGIC, CIC prep courses, and things like that. So we're working towards that. I think there's much more work to do regarding that, but I think we're headed in the right direction.
I think that's fantastic because I think, and I don't know about you, Nikki, but we hear a lot of things about hospitals not necessarily paying for memberships or CIC prep or even the exam or even the APIC text.
Right.
So making those more available and accessible to IPs and hospitals, I think is definitely a step in the right direction.
Yeah, you're only boosting your workforce when you're doing that, and knowledge that knowledge should be available to everybody. Do you think that a requirement for a master's degree will narrow the field for IP applicants? Dr. Merrill, do you want to take that one?
I think, I'm always for advanced education. I think that the skills that you learn in any graduate program only help IPs and increase their credibility. Having said that, I think that there are certificate programs and even certification in infection control that really help foster that expertise. So I think that there's a balance between advanced education requiring a master's degree versus requiring that the person demonstrate competency or expertise. And so for me personally, I think it's difficult to require. For example, in nursing to be eligible to be in infection prevention, to require them to have a master's degree, I think would be limiting. But certainly, and the push with APIC to support the CIC and that nurses in hospitals or IPs in hospitals should be certified when they're eligible, or you should hire a CIC if you are able to, is really, I think, really at the forefront. I think Joan has thoughts on this as well.
Yeah, I do. I would agree that some of the competencies of a infection preventionist would lend themselves to having a master's degree, particularly as it relates to some of the analytics. I find that individuals that do not have master's degrees tend to be a little bit challenged with the data and calculation of compliance rates and HAI rates and prevalence and incidence, and just the statistical analysis that's required in some cases to determine whether something is significant or not. There are certainly individuals in the public health arena that are available to infection prevention programs that are in acute care, for example, or long-term care, to assist with that aspect. I do think it would not be good to require a master's to become an IP. I agree with Katreena that competency and building toward taking the exam and showing that you are certified in infection prevention and control is very important. And we have recently developed a curriculum through APIC and an exam through CBIC for long-term care IPs. And so when I go out and mentor IPs in that setting, that is one of the things that I emphasize, is that the academic education is important, but bear in mind that we don't have but 2 or 3 RNs sometimes populating a long-term care facility. They may or may not have bachelor's degrees, but these are the individuals that are moving into those roles. And we really need to coach, mentor them on what are the competencies and encouraging them to become certified. So I think the academic credentials are important depending on the kind of work you want to do in infection prevention. If you want to be in leadership roles, you want to do research. But I don't think for operational day-to-day infection prevention that it's necessary.
Yeah, I agree with that. Competency is better than a master's, but I do also agree that a master's degree does help bolster a lot of the skills that are needed for the analytics side.
Mm-hmm.
And I wonder, I felt like when I read the article that you all leaned towards Masters of Public Health, but do you see the benefits of other master's degrees, a Master's of Science in Nursing or an MBA, MHA? What's I don't know how to phrase this, but what are the benefits of each?
So this is actually something that's dear to me. Since years ago when I wanted to expand my education and hone my skills, there really wasn't a lot of options available. I had a master's degree. So I have both an MPH and an MSN. So I'm in this like perfect storm spot where I have both sides. And at the time, there really wasn't that much that's available. We're starting to see a lot of opportunities come out from not just infection prevention, but having that MBA, that MHA, having all of that in your arsenal to tackle the problems that we're seeing. One of the things that I thought was really intriguing was we're starting to see Masters of Science in infection prevention and control. So rather than it being a subspecialty of what you're focusing on, it's actually dedicated to infection prevention and control. It's an MS program that's geared to prepare students for frontline and leadership positions in IP. We're now seeing health study division, healthcare, infection prevention, and epidemiology. So there's a few universities that have these specific degrees that are just for infection prevention. So I thought that was really interesting. I don't know if Joan or Dr. Merrill have anything to contribute.
I was just going to say, I think that APIC with their competency model really helped pave the way for what's necessary for IPs. What we're starting to see, Joan addressed long-term care and their unique set of needs, but we're starting to see a change from the lone wolf IP in a hospital setting to hospital systems and clinical ladders, meaning that you have junior IPs that maybe have a bachelor's degree, and then you have supervisors or even system-wide IPs who have master's degrees. The other thing that we're starting to see when you have, let's say, a large hospital and you have a team, they're looking specifically for someone who has, like if they have 3 or 4 IPs, one person with a master's in public health, one person with a micro background, one with a nursing background. And so I think that is just the perfect storm. That is great to have all of us working together with our different specialties.
Right. All brains at the table.
Yeah, I couldn't agree more. I think it's wonderful that we have not only public health, we certainly at the University of Maryland, we had a number of IPs transition from microbiology. These were microbiologists that really wanted to get more engaged in the clinical side of things. And their knowledge of molecular diagnostics was really important as that kind of technology moved into the forefront for us. I agree. The more disciplines you can have as part of your team, the better.
Yeah, I'm like that odd man out. I'm the microbiologist with the MBA. So I guess I don't fit into any sort of mold, but I'm one of those people that can be brought in to add that diversity. That's great.
Yep. Absolutely.
Yeah. Thinking about how we know this is a 24/7 job, and COVID definitely brought to light the value of IP's expertise and the time that they spend. Does APIC have any plans to offer guidance on fair compensation and equitable opportunities? I know that it was mentioned in the article that more research is needed in this area, but do you have any thoughts on this currently?
Workforce compensation and staffing for IPs is a very hot topic right now. In December 2023, APIC launched the APIC Staffing Calculator, which includes an acute care, long-term care, and ambulatory clinic calculator. It's based on our own Rebecca Bartles, who is now, as of October, the executive director of APIC's Center for Infection Prevention and Control Research, Practice, and Innovation. It's a lot. That's a lot.
Yeah.
Her name badge must be really crowded. But I do think as far as compensation goes, we need more research. The research is thin on compensation. And that's why we wanted to specifically call that out in the paper.
Yeah, based on what I've seen historically in some of the surveys that have been put out, it seems like it is all over the place depending on the region of the country you're in, the education level, your title, even male versus female IPs. So it will be interesting to see what more comes from research and then also from industry around what is appropriate.
And I think, too, how much importance and weight the hospital or the system places behind their IPs and their budget all plays a lot into it. And we know that every hospital has to have an IP, but some of them carry many different hats, too. And I don't know if you guys have any information on this, but how many of these respondents were just IPs, or how many were IPs in employee health or quality and risk and patient safety or managers and all the other roles? It's pretty varied.
Katreena, I don't think we had that information specifically. Did identify when we looked at the competency model that there were deficiencies in knowledge regarding employee health and disinfection and sterilization. And we pointed that out in the discussion of the paper. But I would say that we as a discipline are very involved in educational programs. Webinars are given to try to increase competency around those topics that IPs struggle with. And it's something that the organization has identified. There have been some initiatives that have been formed with public health organizations to do symposiums. We've got some other patient safety organizations that have gotten involved. The ECRI group, Leapfrog. Certainly, there is now a fair amount of discussion going on between the leaderships of those organizations with our CEO, Devin Job. I think that we really do need to continue to do educational identification of gaps and partner as we can with other organizations. And that's not just with patient safety organizations. That's with other organizations like AORN, for example, the medical instrumentation, AMI. That is something that our practice guidance group with APIC, which I'm a member of right now, we are really trying to develop liaisons with those organizations to build knowledge.
I think that's a great idea. As we mentioned earlier, we get so heavily involved in some of these other aspects. It's not just hand hygiene, as some people think. I do hope, though, we talk a lot about how the pandemic sort of raised awareness around the importance of infection prevention and the value of our infection preventionists. And I do hope that hospitals and long-term care organizations don't feel like now that the pandemic, and I'm in quotes, is over, that there's not as much of a need for the infection preventionists anymore, and start to consider some downsizing, especially with some of the financial constraints of these institutions. So I think that could be concerning. Any thoughts from any of you around that?
I think that with this increased awareness of what IPs do, I'm hopeful that kind of thing won't happen. But I was also a bit disappointed in the reaction in the pandemic. There were, in some cases, where people were somewhat dismissive of IPs, not inviting them to the table. And that was very concerning to me. So I think when you get a culture of interdisciplinary work and that we're all in this together, I think that they bring in IPs and they respect them and they pay them well, and you have a very robust workforce because you're a team. And I think anytime you get a very hierarchical relationship and your culture is not that you can learn from every aspect, from the person who sweeps the floor, delivers the food, everyone on the team. And when you have that, then IPs are acknowledged for their expertise. So I'm hopeful. But I was also a little bit disappointed. I don't know about the rest of you, about people's reaction. You never know the future.
Yeah, I think there was maybe for some IPs, there was that initial sort of elbowing your way to the table. I think over time, the value was definitely more apparent. I just hope that we don't have any backward slide from that. And speaking of the future, we're curious, Nikki and I are curious, if there's going to be another mega survey and if we have any idea when that might take place.
Yes. I spoke with Rebecca Bartles, who is now over that, and she indicated that we are in the works for a 2025 survey, mega survey. I'm super excited to see the difference because
me too. Yeah.
The other one, was it was finished up in February of 2020. And I can't wait to see the difference.
I know. I think the difference between, I think we're going to see a huge shift in even less nurses coming to the table as infection preventionists. Because I think, like we talked about the COVID kind of bringing to light how important infection prevention is. I think it's going to be interesting to see what the makeup is.
And I wonder too, we kept hearing that our more senior IPs were leaving the workforce, right?
Yep.
So what is the average age going to be? Do we have a lot of younger people that are coming into the field? Do we have more men coming into the field, like that sort of thing? It will be interesting to see as well.
It would be absolutely amazing to put the two side by side, the 2020 and the 2025. It would probably be mind blowing, honestly.
Yeah. It will be. You'll put it together and it will be. Have faith. So what do you think your research findings indicate about the world of infection prevention?
There's
a lot to take in there.
Discussed it a little bit, but I think the interdisciplinary nature of infection prevention and that shift from being mostly nursing to include other disciplines. I think also the shift from hospital-centric infection prevention.
Mm-hmm.
And then I think Joan mentioned this, the competencies and the kind of the self-reported comfortableness. That's probably a bad word, but how they feel like that they need more information. And I think from an education standpoint, I think one thing that we forget is we develop education. We have the annual conference and we think, oh, we've talked about that a lot. But as you change and you get new people into the profession, you need to keep talking about some of these strong points and you need to hit the competencies over and over again in different ways. And I think that it shored up the need for continued support for IPs in their role and continued support in developing those competencies.
Yeah, I would agree with that. I would agree with that. The other thing that I wanted to mention just quickly is about the implementation of infection prevention practices. We really need to address sort of the behavioral aspects of implementation. And one of the fields that I think we need to engage with more, and Rebecca and I have talked about this, is with the human factors engineering group. We really want to promote the adoption and sustainability of these practices. But if we don't take into consideration the workflow, the skill sets, the knowledge base of the individuals who have to implement these practices, we're not going to get very far. I, for years, used to go to my office and bang my head against the wall, literally, about why people were not doing what the science was suggesting we needed to do to prevent infection. And I don't want to see our new workforce being frustrated like I was for 28 years. Hopefully, we can begin to engage some of these other experts in human perceptions, actions, and getting them to assist us.
I think Nikki and I could go on for hours and hours because there's so many different tangents from this research that we could go off on. But thank you, ladies, so much for being with us today. And I'm just curious, are there any big takeaways that you want to leave the listeners with today?
I would say don't feel like you are isolated, and please engage the other departments in your team. There was a great article by David Weber and his group out of the University of North Carolina about building a team to assist you with the development and the implementation of your program. That would be a great article for us to attach to have our viewers, participants take a look at. But I don't think you're going to be able to do this alone. It's very much a team effort.
I think what I would say is that APIC, their website is really robust. There are a lot of resources. And I think that to some degree, I think they're underutilized. I think there's so much to offer. And I think people should connect through those and connect with other IPs, even if they're isolated in a particular area of the country and don't have as much support as Joan is talking about. I think that APIC resources.
I think you're probably right. We hear all the time that, oh, I'm not actually a member of APIC, or, oh, what is APIC? And you're like, this is one of your biggest resources. Please join. And I will say that the networking and the participation on the local chapters is priceless. Just having those experiences with other IPs and being able to ask them questions and learn from them. I learn from people all the time. So I think you're absolutely right we need to just get people more information and just keep them accessing these resources as much as possible. Dana, did you have any last points you'd like to leave us with?
I'd just echo both Dr. Merrill and Joan's sentiments, and then a plug for public health. Don't be afraid of your public health departments. That we're actually there to help you and to support
Huge
you.
partnerships.
Yep.
All so much for being with us today.
Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at APIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other APIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.